Welcome, everyone. Today, we're doing something a little different. We're going to jump right into the hot seat of a general surgery oral board exam. I'll play the part of the examiner, and you can think of yourself as the candidate, walking me through a classic case involving a liver mass. The goal here? To really sharpen our clinical thinking step by step. So, let's get started.
All right, doctor, the clock starts now. Here's your case. A 45-year-old woman presents to you. She's had a week of fever and really bad pain in her right upper quadrant. So, talk me through it. What's your initial approach?
Thank you for the question. With a presentation like this, I'd approach it systematically. My first priority is always the patient, so stabilizing them and getting a thorough history and physical to start building my differential diagnosis. From there, I'll order the right labs and imaging. This will help me really narrow down the possibilities and then create a solid management plan. And finally, I'll wrap up by reviewing the most important, high-yield points for a case like this.
Okay, so, diving right in. My first move is always the bedside assessment. Before I even think about ordering a single test, I need to get my hands on the patient and get a real sense of just how sick they are.
So, on my exam, this patient, she looks unwell. She's febrile. And when I check, I see jaundice under her tongue, which is a big clue for liver issues. Her abdomen is a bit distended, and she's got severe tenderness right where she's complaining of pain, in that right upper quadrant. What's more, percussion gives me shifting dullness, a classic sign of ascites, and I'm also seeing pitting edema in her lower extremities. Putting all these pieces together, this is pointing to a serious liver problem, maybe even with portal hypertension.
Very good. Your physical exam definitely raises some serious red flags. So, what's next? What investigations would you order to start putting the pieces of this puzzle together?
Okay, so for my initial workup, I'm going to need a few key things. I'll start with a CBC, looking for a high white count. Of course, I'll need liver function tests and a coagulation profile to see how the liver's doing. Given the fever, I want inflammatory markers like CRP and ESR, and I'm definitely sending off blood cultures. Now, because certain cysts are on my mind, I'm also going to order specific serology for amoebic and hydatid disease. As for imaging, I'll start with a basic abdominal ultrasound, but I know I'm going to need a triphasic CT scan to really get a good look and characterize whatever lesion we find.
The results are back. Your CT scan shows a 7-centimeter, well-defined, round lesion in the right lobe of the liver. It's hypodense and has that classic peripheral wall enhancement. So based on this finding, what are you thinking now? What's your differential diagnosis? All right, with the clinical picture and those classic CT findings, it's time to build a really focused differential diagnosis. This is probably one of the most important steps because it's what's going to guide everything we do next.
I like to structure my differential into 3 main buckets. First, infectious. A pyogenic or amoebic abscess just fits this clinical picture perfectly. Then there's the benign neoplastic category. Here we have to consider things like a hepatic adenoma, a hemangioma, or FNH. That's focal nodular hyperplasia. And last but not least, we can never forget about malignancy. This could be a primary liver cancer like hepatocellular carcinoma, or even a metastasis from somewhere else that's become necrotic and infected.
Now, it's absolutely crucial to tell the difference between my top 2 infectious causes. A pyogenic abscess, which is bacterial, is going to give you straight-up pus if you aspirate it, and the treatment's IV antibiotics plus drainage. On the other hand, an amoebic abscess caused by a parasite famously has this thick, sterile fluid that looks like anchovy sauce. The key here is that it's treated medically with metronidazole, no drainage needed. Getting this right is a huge deal for management.
Let's move on. Let's say your serology for Echinococcus comes back positive. You've confirmed it's a hydatid cyst. How are you going to manage this patient now?
Well, for a hydatid cyst, how we manage it really depends on what it looks like. For smaller, uncomplicated cysts, especially in someone who might not be a great candidate for surgery, we can consider a percutaneous technique called the pear procedure. It's exactly what it sounds like. You puncture the cyst, aspirate the fluid, inject a sculicidal agent to kill the parasite, and then re-aspirate that agent.
But, and this is a big but, we have to remember that surgery is still the gold standard, the definitive treatment for any cysts that are large, complex, or have ruptured. And here's the most critical point of all, no matter if you're doing pear or surgery, the patient absolutely must be started on albendazole beforehand. This helps sterilize the cyst and prevents some really catastrophic complications from spillage.
Excellent. Let's switch gears. Let's say, in this scenario, the patient also tells you she has a long history of taking oral contraceptive pills. Suddenly, the picture looks a lot more like a hepatic adenoma. How does that change your management plan?
For hepatic adenoma, the entire decision-making process really boils down to one magic number: 5 centimeters. This is the size cutoff that we care about, because once an adenoma gets bigger than this, the risk of it bleeding or even turning into a cancer goes way up.
So the management follows a very clear algorithm. If the adenoma is small, less than 5 centimeters, and the patient has no symptoms, we simply stop the offending agent, like OCPs, and watch it. But if it's symptomatic, growing, or already bigger than 5 centimeters, then the answer is surgical resection. Now, what if it bleeds? Well, in that worst-case scenario, if the patient is unstable, we're going straight to the OR for a laparotomy and packing. If they're stable, we have a little more time, so we can opt for embolization first, followed by a planned resection later on.
All right, doctor, you're doing very well. Before we finish up, I want you to give me a quick, rapid-fire rundown. What are the most high-yield facts, the biggest pitfalls, and the absolute must-know red flags when you're managing any kind of liver mass for an exam?
First up, a huge exam pitfall, and just a critical safety issue in general. If you think you're looking at a hemangioma, which is the most common benign liver tumor, you never biopsy it. The risk of causing a life-threatening hemorrhage is just way too high. We make that diagnosis based on its classic appearance on imaging, period.
Next, a classic radiology pearl. If you see a liver lesion on a CT scan that has a central scar, your mind should immediately jump to focal nodular hyperplasia, or FNH. This is a benign lesion, it has no malignant potential, and usually we can just leave it alone.
Okay, here's a rare one, but it's a serious red flag and a great exam topic. Giant hemangiomas can sometimes lead to something called Kasabach-Merritt syndrome. This is a really dangerous condition where the tumor basically acts like a sponge for platelets, trapping and consuming them. This leads to severe thrombocytopenia and a massive risk of bleeding.
I'm going to say this again because it's that important. With a hydatitis cyst, making a mistake here is a huge deal. You must always start the patient on albendazole before you stick any needles in or take them to the operating room. Why? Because you're trying to prevent 2 disastrous outcomes. 1, anaphylactic shock from spilling the cyst contents, and 2, seeding the parasite all over the peritoneum, which causes a nightmare recurrence.
And one last exam pearl for you, the definitive diagnosis for an amoebic liver abscess comes from a blood test, the serology, which is positive in something like 95% of cases. It's a common misconception, but you almost never see the actual parasite in that anchovy sauce fluid, because it lives in the wall of the abscess, not floating around inside.
Okay, we've made it to the end of the case. You successfully navigated the diagnosis and the initial treatment. So my final question for you is this: what is the single most important factor that's going to determine your long-term follow-up plan? Well, the answer is simple. It's the final pathology report. Because whether that lesion was infectious, benign, or malignant, that single piece of information changes everything that comes next. It's a great reminder that our job as surgeons goes way beyond just the operating room.